Hello, everyone. Thank you for joining us. Today's cancer care virtual seminar topic is metastatic lung cancer. My name is Carmen Boone. I'm an outreach coordinator for the Samaritan Cancer Resource Center, and I will be your host and moderator. This event is brought to you by the Samaritan Cancer Resource Center. We partnered with anyone touched by cancer to provide the support they need to live with strength, determination, and hope in the future. Joining us today is Dr. Nicholas Tedesco, and Dr. Tedesco is an orthopedic oncologist with Samaritan. Thank you so much for being here with us, Doctor. It is now my pleasure to turn the presentation over to you.
Excellent. All right. Well, yes, I'm Dr. Nicholas Tedesco. I do specialize in orthopedic oncology and complex reconstruction here at Good Samaritan Regional Medical Center in Corvallis and part of the Pastega Cancer Center. And so today we're going to be talking about metastatic lung cancer to bone, specifically when it ends up in my wheelhouse. So what we're going to talk about today, first off, is going to be what is lung cancer, how does it spread, and what happens when it does. And then we're going to also talk about what is orthopedic oncology. A lot of folks don't know we exist. That includes many physicians out there. We are few and far between, but we'll go over its history and what we're doing in Corvallis with respect to metastatic lung cancer, especially in the bone. And a lot of this will be redundant if you've ever listened to my talks previously, but it's more for the folks that are new to joining us. So we'll start off with lung cancer as the broad topic. And so there are two main types of lung cancer: small cell lung cancer, which represents about 10 to 15% of all cases, and non-small cell lung cancer, which is about 85 to 90% of all of the cases. There are lots of different non-small cell types, but we parse them out as these two because small cell has a very specific and very unique prognosis, treatment, presentation, everything, whereas a lot of the other lung cancers are somewhat similar in their presentation and in their treatment and things like that. Adenocarcinoma is a subtype of the non-small cell. That's the most common lung cancer in non-smokers, but it's still more common in current or former smokers. So we all know of the smoking affiliation with lung cancer, but folks that have never smoked in their life can get it as well, and adenocarcinoma seems to be the most common in that patient population. So small cell behaves very aggressively, and about 70% of patients who present with this cancer will have already had it spread at the time of initial diagnosis, compared to the minority of non-small cell cancer. So for instance, they present when they're still only in the lung or only one spot. The small cells tend to show up very late in the disease process. They seem to be very minimally symptomatic or problematic until it's very late in the disease. Each year, there are about 235,000 new lung cancer cases in the entire United States. It also accounts for about 131,000 deaths each year in the United States. This is the deadliest of all cancers as a result. So metastatic lung cancer are cancerous cells that have spread either beyond the lungs or from the main tumor in the lungs to another part of the lungs. Most commonly, it spreads through the lymphatic channels, and so it will show up in the lymph nodes, other parts of the lungs, and then bone, liver, or brain most commonly, but really it can spread anywhere. Specifically, what we're going to talk about is when metastatic lung cancer spreads to bone. By definition, because it is now spread far away from its native place, it is considered stage 4 cancer. 30 to 40% of all patients with lung cancer will develop bone metastases. So this is a real problem for a big portion of these people. Only about 11% of patients with bone metastases will survive greater than 2 years. So it tends to portend a very grave prognosis if this shows up in the skeleton. Some of this data is also older, and now that we have newer and more targeted chemotherapy agents, we are seeing patients live longer, but we haven't been able to tabulate that on a population basis yet, but I'd be willing to bet that that number is going to change the next time we meaningfully look at this. The length of survival, though, does depend on the main diagnosis, whether it's small cell versus non-small cell and which kind, the degree of the disease burden, meaning is it in one spot, multiple spots, in one bone, multiple bones, in organs and bones, all of those things matter. And then the use of certain chemotherapies that have already been tried before versus still remain to be tried, and then other patient health factors, based on patient age and their underlying health to begin with. Historically, you would have to travel a long distance to find an orthopedic oncology specialist, but most cases of this were easily managed by a local community orthopedic surgeon. So when cancer spreads to bone, it presents as a couple of different problems. So the first problem is that you now have a cancer in the bone, and it can be painful, but the second problem is that it can structurally compromise the bone. And so they often need orthopedic intervention to stabilize the bone or even fix it if it has already been fractured. So because the prognosis was so poor and the fixation methods are relatively simple, most general community orthopedic surgeons can manage this. However, as we just alluded to previously, patients are now living a lot longer with more advanced stages of disease because of the better chemotherapy agents and more targeted agents out there. And so this presents new challenges and requires more advanced expertise. So more and more of these patients actually need to see me rather than their community orthopedic surgeon. I've been servicing the southern half of Oregon since 2016. I'm one of only 5 orthopedic oncologists in the entire state of Oregon, and I'm the only one outside of Portland. In fact, I'm the only one between Portland and Sacramento, so I cover a very large area that gets shuttled here into Corvallis. So in terms of, what is Good Samaritan doing and what are we doing for research specifically and our national presence as it relates to lung cancer and metastatic lung cancer is, first off, our medical oncology team here does generally participate in multiple clinical trials. So if there is new drugs and chemotherapy agents out there for lung cancer, often we can jump on that and be part of those clinical trials so we can offer those to our patients here. I personally keep track of a local database and case repository of all the patients we operate on precisely so that we can look at that data later and try to optimize outcome and answer important research questions. We have plans to contribute starting either the end of this year or early next year to a national sarcoma database, which is a specific subtype of cancer, but it's going to include metastatic carcinoma cases like lung cancer as well. And so the hope with that is that more than just my local database, we can now pool data from the entire United States and start to answer better questions and improve our management strategies for this particular disease. I currently serve on the Guidelines and Evidence-Based Medicine Committee nationally with the Musculoskeletal Tumor Society, which is the society that oversees orthopedic oncologists. And the Evidence-Based Medicine Committee is tasked with developing appropriate use criterias and clinical practice guidelines that help drive and educate physicians out there that manage these things on the most appropriate and the most evidence-based techniques and management strategies available. I serve on the board of directors for the Musculoskeletal Oncology Research Initiative, which is a group of orthopedic oncologists at smaller centers like our own here, rather than at MD Anderson or Sloan Kettering in New York City or the Mayo Clinic. And what this group is designed to do is to try and function like one large center like that. And so we can pool our resources quickly and easily to perform better research into these challenging topics without just having to use a single center database where the numbers might be small or the treatment is too homogeneous to make any reliable comparative data. We have a residency program here that trains the next generation of orthopedic surgeons, and we just had our first resident go into orthopedic oncology graduate this past year, and we have another one currently in training that is his plan as well, as eventually to go into orthopedic oncology. So hopefully we'll continue to be able to provide care through our training of these residents to the population throughout the US as our residents go on and spread out. So in terms of treating metastatic lung cancer, there are several algorithms that do exist based on the patient age, their health, and then their stage of disease. And we'll talk about that. But it requires a panel of experts and multidisciplinary care. So a lot of these patients that are battling with this disease come to what's called our multidisciplinary tumor board. So the patient themselves doesn't show up there, but rather the physicians that are managing their case bring it there, and it's where we can all review it and then start to weigh in based on, you know, the evidence within our specialty on optimal management, and then all start to determine appropriate timelines and order of treatments, as well as get the entire team that's going to need to care for this patient on board so that we're all aware of what's going on, and we cut down on redundancy so that I'm not ordering the same tests as the medical oncologist and things like that. So it's patient-centered care, and it's customized to their particular situation. But you can see in the background here, you know, the red lines of communication to the patient are where the patient sees all these folks, but the blue lines are where we're all communicating in the background to try and optimize the management for each individual patient. In terms of stage of disease and why that matters, is stage is sort of categorizing where the disease has spread to. And that has important implications both prognostically, as we talked about before, where survival is poor when it's already in the skeleton. But it also has implications in terms of treatment. So depending on what stage they're in, they may be eligible for totally different treatment methods that are aimed at, you know, hopefully curative intent whenever we can, but otherwise palliative management if we can no longer beat the disease. And palliative management is designed to prolong survival as much as possible, but keep the patient as comfortable as possible and as functional as possible as well. So that's where orthopedic oncology comes in as part of this multidisciplinary team in management of this. So what is orthopedic oncology? Well, it's the surgical management of tumors of the trunk, buttocks, arms, and legs, basically everywhere but the spine and the head and neck. It involves bones, nerves, or soft tissues in these regions, and we manage both benign and malignant tumors. The common benign tumors that we see are things like lipomas, nerve sheath tumors, and what's called osteochondromas, which are these benign skeletal tumors that tend to show up kind of in our teenage years, but they can become more symptomatic over time. The common malignancies that we manage are things like sarcomas, lymphomas of bone, multiple myeloma, and then I bolded here metastatic carcinoma, because that's where lung cancer falls into that category. Tumor-like conditions are things that we manage as well, which are things that essentially present like a tumor, or they're managed like a tumor, where you have to remove tissue or you have to reconstruct defects that are created. So those are things like complex infections, immune system reactive processes, or things like hemangiomas, which are these abnormal collections of otherwise normal blood vessels in an area where they don't belong. So orthopedic oncology as a specialty began in about the 1970s, basically once chemotherapy became a bigger option for patients with osteosarcoma, which is a very specific type of bone cancer. Previous to the 1970s and previous to the use of chemotherapy for these diseases, if you showed up for a disease in your skeletal system, typically the treatment was amputation right off the bat. And general surgeons did that, orthopedic surgeons did that, you know, all kinds of folks. And so once we had chemotherapy and outcomes were greatly improved, and now we could save limbs and we didn't have to amputate them, the surgeries became more and more specialized. And so that's where these four guys kind of broke off and started creating this as a specialty. Excuse me. So the first is Bill Enneking. He was at the University of Florida. Henry Mencken, he was at Harvard University. Michael Simon was at the University of Chicago, and Jeff Eckert was down at UCLA. And so if you had one of these rare diseases or needed one of these more complicated surgeries, you'd have to travel a very long distance, depending on the region in the United States you were in, to find one of these four guys. Currently, though, we have about 150 active orthopedic oncologists in the US and about 250 worldwide. So while that seems like very small numbers, which it is, we pretty much have the population covered. Some folks still do have to travel long distances, but at least a couple of hours rather than a few days. If you lived in, let's say North Carolina and you had to get to Harvard for your management or something like that. So what exactly is limb salvage surgery? And that's basically what it says, saving the limb. So instead of an amputation, what else can we do? Sometimes we can simply remove the tumor and do nothing else. Go in there, cut it out, close it up, walk away, and the patients will do very well. Sometimes we remove the tumor, but then we create defects, and so now we have to manage that. And so that can include removing the tumor with internal fixation, with or without augmentation, like adding bone cement or bone grafting to the defect. And so that's where you have a major structural deficit, where removing of the tumor is still going to leave behind a very dysfunctional limb. And so with internal fixation, with things like plates and screws or a rod or a nail, we can then stabilize the bone and keep it functional. Sometimes we have to remove the tumor but do a soft tissue reconstruction instead of the bone. So those are things where we get plastic surgery involved, or sometimes even we do those things with muscle advancements or transfers, or even vascular bypass if major blood vessels have to be involved or removed with the tumor. It can also include tumor removal with bone reconstruction. So rather than fixation, we remove the bone and we rebuild it basically with metal and plastic. So one of the examples we wrote here are these intercalary procedures. So that's usually where a lesion shows up in the shaft of the bone, and so you can remove just the shaft and preserve the joint above and below, but now you have to jump that gap. And so you can put in there either bone graft from a cadaver donor, or you can rebuild it with metal with anchoring stems that go into the remaining cut bone. You can do tumor removal with artificial joint replacement. So the same exact thing, except now we have to sacrifice a joint. And so now we can rebuild that, much like folks get total hip and total knee replacements. We can do that on a much larger scale, where not only do we just replace that joint, but we replace bulk bone coming in behind it as well. Also, limb salvage surgery involves management of the failures of these reconstructions with revision surgery. Sometimes when these fail, they're so complicated and so dysfunctional that we still may need an amputation. But a lot of times, even the salvage of these will allow us to save the leg or save the arm or whatever we need to keep that patient's anatomy and function as best as possible. So we're going to go through a couple of cases with some examples of what we mean by each of these. So tumor removal alone, this is a slide here that's not actually a lung cancer patient, but more just to kind of illustrate the point where, as we talked about, it's just cutting out the tumor. Well, sometimes it's not that simple, and cutting out the tumor alone can be very challenging. And so this was a case example of a patient with a tumor in their hip or in their pelvis bone right near the hip. And if you can see my pointer on the screen there where we're zeroing in, here's the tumor eating the bone away. And so you can see the bones kind of disappearing in areas, but the hip joint is right here, the ball in the socket. And so we have a very thin gap to thread here to try and cut this bone out without either getting into the tumor and leaving tumor behind, which would be bad, or cutting into the hip joint and destroying that, which would be bad. So this was an example where we can use computer navigation, where we use a CT scan of the patient's pelvis in multiple planes and even a three-dimensional reconstruction. And then during the surgery, we can use infrared readers on our instruments that can tell us exactly where on the pelvis we are. So I know that I can cut exactly right in between these two structures and make a safe cut there that can remove the tumor and save the patient's hip. Internal fixation. So here's an example of a patient that did have metastatic lung cancer that showed up in the humerus bone. And what you can see is portions of the bone right down here in the distal third of it have sort of been removed and eaten away by the tumor. Unfortunately, that weakened the bone, and then the bone fractured. So you can see the fracture line right there. And then right here, this little step off where the bone has shifted just a little bit. So we can use plates and screws or bone nails. And so here's an example of plate and screws. So what we did was we went in there and we did plate and screws, but because of the structural damage, if we don't do something about that, this plate eventually is going to fatigue, fracture, and fail. So what we do is we scoop all that tumor out of there and we fill that cavity with bone cement. Very similar to how a dentist fills a cavity in your tooth, but on a much larger scale. That provides immediate structural support. It allows an additional point of fixation for our construct, and it gets rid of the tumor in the process. We usually will also back this up with radiation therapy to kill any additional tumor cells that may have been left behind, because if they're still there, they're going to grow again, they're going to eat away more bone. And so we combine this treatment together along with the patient's chemotherapy, again, as a multidisciplinary mode of treatment to basically try and eradicate this and reestablish a functional limb. Endoprosthetic reconstruction is what we alluded to earlier with the rebuilding of bone. So endo means inside, prosthesis, just like a prosthetic in a patient with an amputation, it's an artificial part. And so you have an artificial part inside the body. So things like the intercalary replacement that we briefly discussed, where you remove portions of the shaft of this bone, you put anchoring stems up and down it, and you rebuild it and jump that gap with metal so that we can preserve the ankle joint down here. Oops, sorry. And the knee joint way up top here that's just off that x-ray. Another option are things like simple joint replacement. So this is a hip replacement for a patient that had metastatic lung cancer in the neck of their femur. And so just like we cut the neck of the femur when someone has bad arthritis and we create a new hip joint, we do the same thing there, except this time that's also with the goal of removing that tumor. We can do what's called mega endoprosthetics, which is more than just a simple joint replacement, it's replacement of bulk bone. So you can see this anchors into the bone, but we haven't replaced the bone here. Whereas this is what's called a total femur replacement. So there's an artificial hip at the top, an artificial knee at the bottom, and a completely artificial femur all the way in between there. So we don't preserve any of the bone when we have to move it in its entirety. Then the last thing is something called custom endoprosthetics. So custom normally comes in when we have complex defects or we have to make a weird misshapen cut to safely remove the tumor that doesn't match up with any known implants out there, or most commonly in the pelvis. So if we remove a huge chunk of the pelvis and we have to somehow rebuild that and establish an artificial hip joint, we use a custom implant. And the way we do this is, again, we scan the patient with a CT or MRI, we send it to a company and we show them where the tumor is, where we need to cut that tumor out. Then they take that area where we cut it and figure out how to rebuild it and get fixation into the remaining bone to anchor it and then reestablish a joint. So the manufacturing of those does take quite some time, but it allows us to do much more complicated things and save many more limbs and much more function than we were able to do before they existed. So in terms of endoprosthetic reconstruction, so as we talked about, they're used to remove the tumor, rebuild the bone, and provide structural support, but also to reestablish joint surfaces or bypass failed bone healing mechanisms because of the presence of the tumor. So here was an example of a patient with lung cancer again, and I put the arrow here to show you. So if you look at the other femur, as we go up and form the hip joint here in the pelvis, you can see this thick white line, that's the outer wall that gives bone its strength and its structural integrity. But you can see over here, that white line peters out and actually disappears right here. So this bone is getting very, very weak, and just a simple step could fracture this bone. So what we do is we go in there, we cut that tumor out, and we jump that gap with all this metal, and we recreate an artificial hip joint. And you can see this haze around this. So this is cemented in there so that it's immediately fixed into the bone and provides immediate structural support to where this patient can get up and get walking as soon as surgery is over. So what are some complications with these, big surgeries, or technically difficult or challenging surgeries, or where we have to remove a ton of anatomy and replace it? Well, you name it. We can see just about every complication you can possibly conceive of. There are medical complications because these surgeries can be very large. There can be a lot of blood loss. You can need blood transfusions, and anything can happen. And then you, of course, can have the mechanical or structural problems with whatever you use to rebuild it. You can dislocate joints. The implants can break. Pieces and parts in them can dislodge and fall apart. So informed consent with the patient and their family is a huge part of management of this. Disclosing here's the issue, here's how we can fix it, but here's all of the potential complications that can arise. But here's the main goal and benefit to this surgery. So a lot of it also comes down to the patient's goals and their expectations. If the patient is expecting something that a certain construct can't deliver, then that's not maybe the most appropriate construct for that patient to get. Age and life expectancy play a role where two patients with very similar things may choose very different treatment options based on expected survival or current medical conditions and things like that. So in other words, when it comes down to surgical management, there actually isn't an algorithm. It's really just a talk behind the scenes with all your doctors, and then a talk with you and your family to decide what's going to be the most appropriate thing here, what's going to accomplish the most goals while sacrifice the least amount of complications and things like that. And then we come together and make a decision together. So in conclusion, basically, orthopedic oncology is but a small part of the multidisciplinary care for these complicated cases here at Good Samaritan. Bone support surgically and medically are mainstays of treatment of metastatic lung cancer. And so medically, what we often use are things called bisphosphonates or Prolia or Exjava or any of these other agents that you may have heard of out there or seen advertisements for that are designed to strengthen bone. And what they do is they try to strengthen bone that's already been damaged or try to prevent the bone from being damaged by the cancer by structurally supporting it with medicines that enable the cells that support bone to do their job, basically. Limb salvage surgery is a burgeoning area of clinical and technological advances with many options currently available, and these are still growing. We're getting better with our custom implants, our ability to offer reconstructions for many areas that once upon a time we had to amputate is growing. So this continues to be a huge area of technological advance. Each case must be tailored to the specific patient, as we talked about before. Anatomic considerations matter. Where is this and what needs to come out? What is the stage of the disease? What's the bone structure adjacent to this, and how close is it to the joints that are around it? What are the goals of the patient? Did we adequately inform the patient and their family so that they can make an appropriate decision for their treatment needs? And then what's the patient's expectations? What are their expectations for hospital stay, for recovery, for long-term outcomes? All of those things play a role. If these topics are of interest to you, I've included a few here that you can read on further. So the first one is just the page for the Samaritan Pastega Regional Cancer Center, so you can find out a little bit more about us and what we do. The next one is through the NCCI about lung cancer specifically. So if you're looking for what is it, some more data on it, what's survival like, all of those things. And then the MSTS, as we talked about earlier, that's the Musculoskeletal Tumor Society, which is the consortium that sort of leads and oversees orthopedic oncologists and a lot of the research in this country on these conditions. So that being said, I know we're finishing very early, but I wanted to leave enough opportunity for folks to ask questions and or throw in some comments, and I'm happy to entertain those and answer those. But I definitely appreciate your time and thank you for listening today.
Thank you, Dr. Tedesco. So now we will ask our participants to think about their questions and comments, and we will give our audience a few moments to write any questions and comments in the questions menu. While our audience are entering their questions, we'll go over some contact information and upcoming events. So if you would like to obtain more information or resources about cancer, feel free to contact the Cancer Resource Center by phone, email, or visit our website. If you are interested in upcoming events, please contact us to subscribe to our Samaritan Cancer Resource Center newsletter. You can also find us on social media. If you are interested in registering for these couple of upcoming events, send us an email or call us. We will have webinar on what is palliative care on Tuesday, November 15, and cancer during the holidays on Thursday, November 17. Now, let's go over your questions. Yeah, more kudos. Thank you to Dr. Tedesco. Thanks for the great and valuable information. So if you have any questions for Dr. Tedesco that you would like to be answered privately, please email us at the Cancer Resource Center at samhealth.org, Cancer Resource Center at samhealth.org, and we'll be happy to send that to Dr. Tedesco so you'll get an answer. Now, thank you so much to our speaker for sharing your time and knowledge with us. And thank you all who joined us. Thanks, Dr. Tedesco. And
Yeah,
thanks,
great.
everybody.
Thanks, guys. Yep, and again, feel free to reach out.
Again, thank you so much, everybody. We'll see you on the next one. Have a wonderful day. Bye.